I'm really thrilled to have Mary down here because she had to travel a good way to come. Mary's a health analyst. She's author of Emergency Irish Hospitals in Chaos, and I would advise any of you to get her book. She's been a health activist for 25 years. Even though she's in Dublin, she knows our hospitals around Munster really better than we do. And really, she's a person we need to listen to right now. Why we're where we are with the hospitals, where we need to go to save them, because we now are at the point where we have to think of saving our hospitals, and it will be too late if we don't see it soon. So it's our whole system needs to go on the road to recovery to keep the theme of the day. Mary.
Good morning, Cathy. I'm sort of a show. I got to go a new film or show. I was in green squilching the loch. Now, I suppose Ray, in a sense, has unveiled what's going on in economics very clearly and very well. Kathleen has done the same, uncovered what's happening in fishing, and I want to do something similar in health, and particularly related to hospitals, because I suppose this is the high point of danger at the present time. Now, public hospitals have become an endangered species in Ireland. Under current government plans, most of them will soon become extinct. Should we care? In recent years, smaller public hospitals have been increasingly depicted as public enemy number one. These hospitals, some of you may not know, have been on death row for a number of years, and people are now being prepared for their demise. Doing this requires an army of so-called expert groups. Groups such as Hanley, management consultants such as Teamwork, and spin doctors such as NKC. Implementing the Hanley report will see all inpatient services, all of them, of an emergency nature, funneled through just 10 or 12 public hospitals. Now, nobody quite believes this, or most people don't, but it is actually happening. And all the rest are just slated to become daycare centres. Maybe they'll do rehab, or minor injuries, or a few lumps and bumps, anything that doesn't actually need the presence of a doctor overnight, because those doctors are being removed. Now, this may be good for career prospects in nursing, but it is actually going to be bad for patient health and for the welfare of communities. We're now facing the biggest closure of beds and services since the asset stripping of the late 1980s. And again, I would point out, this happened under a Fianna Fáil government. So we should remember that. And those beds have never been put back. So what we're doing today is we are taking from where there is already a shortage or a deficit. And in fact, our bed-head ratio here in Ireland is one of the worst in the European Union. But today what's happening is that our public health system is being stripped out by stealth under the banner of reform. Government bed-cutting programmes have been dressed up in various clothes, in robes, such as, for example, the National Cancer Strategy. A good thing, right? Think again. A new language has been developed, full of weasel words, like regionalisation. Did any of us know what this meant 10 years ago? Do we still know? But these were words that had a purpose. And the purpose is to add value to proposals aimed at restructuring our health system and turning it into an American-style healthcare system. A private system, in other words. Words no longer mean what they say in this brave new world of excellence. And excellence actually all started back in the early 80s in a book called In Search of Excellence, written by some American management guru. I know Ray wouldn't mind my saying this if he was here. But if you take HSE's so-called transformation programme, what I would argue is that this is actually a decimation programme that will see 40 public hospitals in this country terminated with extreme prejudice, while key stakeholders are bought off or lulled to sleep by spin doctors paid on average, €1,400 per day. This is the world we now live in. A recent report, published last year in fact, by the HSE and produced by PA Consulting, envisages cutting public patient beds. And this was the heading on the table, public patient beds. At the moment, we have 13,000 beds almost. When the bed cutting programme has finished in 2014, 5 years' time, we will be left with just under 8,000. Now, this represents a total bed loss nationally of almost 5,000 beds, which is around 40%. And Kathleen talked about our fish stock. Well, I'm now going to talk about our bed stock, our national bed stock of 40%. So we are going to lose 40% of our national bed stock, beds for public patients. So I'm not talking here about private hospitals, I am talking here about our public hospitals and our public voluntary hospitals. So this is what the plan is, the great plan. But we should remember that no country in the developed world has actually done this. No country, except Ireland, has set out to eliminate its tier of second-level hospitals. Take the A&E department in Bantry Hospital, for example, which has been reduced to office hours. What kind of an A&E service is that? An office hour A&E. But this is part of a larger plan, a plan to close the hospital. And this is what's coming down the line. The teamwork report on the South, which I believe has been finished quite recently. Well, who knows really when it was finished, because it's not being published. But that report is going to recommend the closure of all smaller hospitals in the region, in the southern region. But it's not going to be released, I have been told, until June, until after the elections. So the government doesn't have to pay the price. Maybe. Well, we'll have to wait and see, I suppose. But what I want to show you really more than anything is that this decimation programme, as I prefer to call it, of the HSE, and we should remember it's also the government's programme, not just the HSE's. It is a vast, untried experiment predicated on mass hospital closures. But if you take the government's claim that closing hospitals can somehow be made up for by something called primary care, community care, ambulance services, that these can actually safely replace hospital inpatient care, well, I can tell you that there is no evidence to show that this is the case. Absolutely none. Nor has it been done in any other country in the world that I'm aware of. We've also got something called American models of chronic disease management. And these have actually been imported here. You can actually go on the website of the Department of Health. You can actually see it for yourself. Chronic disease management. Now we're talking patients here, we're talking people. But this is what it's called chronic disease management. It's coming from the States, and it is another vast, untried, untested experiment. These models, these are commercial models, ways of providing care by companies for profit. These are only in existence for 2 or 3 years in some cases. They have not been tried, they have not been tested. Nobody knows if they'll work or not, but we are bringing them in. We are bringing them in lock, stock and barrel, not just going to pilot them in the South or in the Midwest or, in the Northeast or wherever. These are actually being brought in wholesale right across the country as we speak. Nor is there any good evidence to support the doctrine, and it has become almost a religious doctrine, that bigger volumes result in better outcomes for patients. Where is the evidence for that? There isn't any. There is no good evidence to support this notion. We read it week after week after week in the newspapers, but it simply isn't true. It's true for a handful, like 5 really, really complex procedures that aren't done anyway, ever, in smaller hospitals.